Hello and welcome. I'm Joseph Saramelli. I oversee grand rounds for the Department of Psychiatry and Behavioral Sciences, and thank you for joining us for today's grand rounds presentation. This is the first presentation of the grand rounds series 2021-2022, first of the year. Last year, grand rounds was organized around 4 different types of presentations in education, clinical updates, research, and in well-being and development. And for this year's series, we're trying to organize presentations more so around a theme, which for this year, we're calling Next Steps in Care Include. And next steps in care can mean a couple of different things, I think, including new approaches to treatment decisions, explorations of new treatments, as we'll hear about today, new locations for delivering care that we'll hear about twice this month, next steps in who will provide care, as we'll learn about in 2 weeks when we hear about approaches to applicants to the psychiatry residency program, or next steps in matching clinical assessments to treatment choice, like we'll hear about 3 weeks from now. The general goal for this year will be to have many to most presentations on this theme. I want to mention a core group of us working on the Grand Round series. I oversee the series. Samhar Braha is the series coordinator and does communications, and Mike Walker is the technology expert for this series. The series is funded by the Ripley Fund, and today's presentation is sponsored by the Garvey Institute for Brain Health Solutions. Our presentations are recorded and archived at this website on our department webpage. And throughout the presentation today, you can submit questions, which I can go through at the end of the presentation with Dr. Griffiths in the Q&A section. I'll put the link for the speaker evaluation in the comment box, and please complete the evaluation after today's presentation. Now for today, we have a new colleague in our department, Dr. Nathan Sackett, who will introduce today's speaker, Dr. Roland Griffiths.
Great, thank you. So Dr. Griffiths is a professor in the Department of Psychiatry and Neurosciences and director of the Center for Psychedelic and Consciousness Research at the Johns Hopkins University School of Medicine. His principal research focuses on the behavioral and subjective effects of mood-altering drugs, and he's the author of over 400 scientific publications and has trained more than 50 postdoctoral research fellows. Dr. Griffiths has conducted extensive research with sedative hypnotics, caffeine, and novel mood-altering drugs. About 20 years ago, he initiated a research program at Johns Hopkins investigating the effects of the classic psychedelic substance psilocybin. Over the past 20 years, Dr. Griffiths has become one of the most influential researchers in psychedelics and has inspired countless researchers working on many influential and powerful studies using psychedelics for mood disorders, substance use disorders, anxiety, and many others. I had the pleasure of meeting Dr. Griffiths as a psychiatry resident 2 years ago when I read his work and was captivated by his lab. I had the great privilege of traveling to Johns Hopkins, meeting Dr. Griffiths and many members of his team. And now I'm a junior faculty working with a great group of collaborators, and we're in the early phases of developing our own research in psychedelics at the University of Washington, something that we couldn't have done if it were not for the pioneering work of Dr. Griffiths. We're so excited to have Dr. Griffiths here with us today, giving us a talk titled Psilocybin, Neuropsychopharmacology and Therapeutic Research. Dr. Griffiths, thank you so much for being here today.
Well, thank you very much, Nathan. And I'm delighted to hear that you're getting together a group to initiate this kind of research. So what I want to do today is talk about psilocybin, with which we've worked the last 20 years, and focus some on the neuropsychopharmacology, just to kind of drive out the mysticism of what's going on, although we surely haven't tied down mechanisms of action, and then turn to therapeutic research. This is just my standard acknowledgement disclosure slides. Our research has been funded by a variety of philanthropic sources, a little bit of funding from NIH. I'm affiliated with the Hefter Research Foundation and doing some work with the USONA Institute. So we have been conducting research with psilocybin at Johns Hopkins now for some 20 years. And about 2 years ago, due to very generous philanthropic support, we were able to establish the Johns Hopkins Center for Psychedelic and Consciousness Research. And since that time, a number of such centers are popping up now in academic centers. But I showed this slide just to illustrate that I'm presenting work as part of a very talented team. Right now, we have 6 core faculty members, 6 postdocs, several affiliate investigators, and more than 20 additional staff. So psilocybin, it's a naturally occurring tryptamine alkaloid. It's the principal psychoactive component of the Psilocybe genus of mushrooms that have been probably used for thousands of years within various cultures. With respect to background, psilocybin is considered a classic psychedelic, and these compounds represent a structurally diverse group that binds serotonin 2A receptors and produce a unique profile of changes in thoughts and perceptions and emotions, often experienced just very powerfully as deeply meaningful experiences. Examples of these compounds include the tryptamines, of which psilocybin and DMT and LSD are examples, as well as phenethylamines, which includes mescaline, the active ingredient in the peyote cactus used by the Native Americans. So historically, as I'm imagining most of you are familiar with, there was a lot of research done with classic psychedelics in the 50s and 60s. And then we hit the psychedelic 60s, and research with this set of compounds went dormant almost worldwide for a period of decades because of safety concerns related to the perception of overuse and harm. And I think this was largely a misperception, but we experienced a cultural trauma, if you will, around these compounds. Just by further way of background, talking about abuse and risk. So psilocybin, of course, is a Schedule I compound. So right now, there's no recognized medical use. It's illegal to acquire or use psilocybin except under approved FDA protocols. Lifetime prevalence of non-medical use of these classic psychedelics is about 14%, but perhaps not surprisingly, given all the attention that psychedelics have received in particularly recent years, this is trending upwards. NIDA, the National Institute on Drug Abuse, doesn't consider psilocybin and other classic psychedelics to be drugs of abuse or addiction per se, because they don't produce compulsive drug-seeking behavior. And medical emergencies from psilocybin is really very rare. But despite this low risk of abuse and toxicity, there is concern about exposure because of very real potential adverse effects. And most prominently, I would underscore panic reactions that would lead to people engaging in dangerous behavior or putting themselves or others at risk, and then possible precipitation of enduring psychiatric conditions. And we've been very interested and concerned about downside risks. And we ran a large survey published in 2016 where we documented these kinds of adverse events from an internet survey of almost 2,000 individuals who reported having very difficult experiences after taking psilocybin. So this doesn't give you a base rate of these kinds of experiences, but they do document them. And so in this population of people who had very challenging experiences, 11% reported putting themselves or others at risk of physical harm, 3% sought out medical help, and I think most salient to me is that 10% reported enduring adverse psychological symptoms lasting greater than a year. So these can be consequential adverse events, but notably such effects are extremely uncommon in laboratory studies. So under these conditions where we can carefully screen, prepare, and support people before and after sessions, we can reduce the probability of significant adverse effects to virtually none. So let me now launch into a little bit more about mechanisms of action. I already mentioned these substances bind serotonin 2A receptors. They function there as agonists or partial agonists. And this area of basic preclinical research is exploding. This is a figure from the Brian Ross lab just last year, showing the serotonin 2A receptor. And what they've done here is determine the active state structure of the serotonin 2A receptor when it's bound to a prototypic hallucinogen. And this is represented represented by the pink here in this figure. So this shows, and the implication of that, determining the active state structure, is that this is going to launch a whole cadre of development of new compounds that bind selectively this receptor in the active state. So I think we can expect a lot of new molecular entities coming into research focus, which I think will be just really interesting. So this slide just illustrates different slices, different levels of activity that we can examine with respect to trying to understand mechanisms. So here, this just shows the distribution of 5-HT2A receptors in a human brain, and they're, particularly highly distributed in seminal areas of brain. One point of which is pyramidal or layer 5 neurons in the cortex, and so what's happening at the single neuronal level? What we're seeing is massive depolarization and then rapid firing of these neurons. This rapid firing results in profound alteration of cortical signaling. And here we have a cartoon of either EEG or MEG measures, changing the entropic state of the brain. So there's a loss of a typical rhythmic activity. This is under placebo, and this is under a high dose of psychedelic, and that's said to be high entropy. And surely that is related. And then up here we have global brain connectivity. This is from an MRI study. And the left-hand panel is showing different brain regions. These are networks that are represented in similar colors, and you can see most of the crosstalk, which is represented by the lines connecting these dots, is within network connectivity. And you give psilocybin or LSD, and you can see you get this widespread connectivity across different networks that don't normally speak to one another. And this isn't just randomness, because the thickness of these lines represents the weight, the level of communication going on. Now that subsides when psilocybin is metabolically eliminated. But the idea here is that this may result in novel patterns of global connectivity, which resolve after the drug is eliminated. And it's hypothesized that in the case of treating psychiatric disorders, misfunctioning or so-called damaged networks may subsequently reconnect in better, healthy, more functional ways. And so the analogy here is to resetting a computer system. So now I'm going to turn to different specific networks, and there's a lot of very interesting work going on. The network that's probably gotten the most attention has been the default mode network, which is thought to underwrite self-referential activity, obsessional thinking about oneself. And it goes online, and its activity is increased with things like depression. And what this slide is showing is that psilocybin and other classic psychedelics decreased activity in the default mode network. And it's interesting because that is also the case in meditators. So long-term meditators have decreased activity in default mode network. And that kind of fits with this nice face valid level of explanation. Who knows if it's right, but it's decreased sense of self-referential processing, decreased narrative structure on self, and just more openness. There are several different network and conceptual models that have been proposed. And again, this is an active area of research. Franz Vollenweider out of Switzerland has really focused on alterthalamic gating within the cortical striatal thalamic cortical loops. And they posit that results in overload to cortex, which may account for increases in sensory perception and cognitive disturbances. Robin Carhart-Harris and Carl Friston from the UK have posited another model, what they call rebus, relaxed beliefs under psychedelics. And here they posit that psychedelics disrupt the hierarchical nature of brain by relaxing the weightings of priors, leading to a decrease in top-down and increased bottom-up information flow. And that's received a lot of attention. It's actually a very interesting idea from which to posit different kinds of effects that we can test at the brain level model functioning. And then in our lab, Fred Barrett has really focused in on the colostrum and looking at the cortical colostral cortical model. And that posits this central role for the colostrum, which is very densely expresses 5-HT2A receptors. As a matter of fact, it's probably the single most densely expressed area for serotonin 2A. And it has substantial connectivity throughout the cortex, so much so that Francis Crick at one point posited that the colostrum might be the seat of consciousness. And Fred is interested in assessing activity, and his hypothesis is that it disrupts these canonical cortical networks. And this was figure from Neuroimage of last year that Fred published, showing that indeed there were changes in the frontal parietal task control network, the auditory network, task, and also the default mode network. So that's an interesting area of exploration. Another area, and we know very little about it, but again, I'll point to some recent data from Fred from last year, and that is what accounts for the enduring effects of these compounds. So it's one thing to explain acute effects, but the hallmark signature of why these drugs are interesting clinically is because some types of effects and changes endure. And in this study, what Fred showed is that psilocybin transiently reduced amygdala response to emotional and neural and neutral phases. So this is the green, this is 1 week post psilocybin. And so there's some decrease in amygdala responsivity to emotional reactivity, if you will. And so that's an interesting hypothesis that we're modulating the kind of underlying reactivity of brain to emotion function. Let's see, in terms of other levels and concepts relevant to biological mechanisms of action, psychedelics have potent anti-inflammatory effects. And so that's a wildly interesting area because inflammation may account for a number of psychiatric disorders. They also produce structural functional neuroplastic changes. So there's increases in neuridogenesis, spinogenesis, synaptogenesis, all mediated through different signaling pathways. And just earlier this year, this was out of Yale, this group showed that psilocybin induced rapid and persistent growth of dendritic spines and frontal cortex in vivo. With all of this interest in the basic underlying neuropharmacology, there's arisen currently a debate about whether the basic underlying changes to brain function account for all of the effects of psychedelics. And some people have posited that subjective effects may not be even necessary for producing therapeutic effects. And we had a set of dueling commentaries about this topic in ACS Pharmacology and Translational Sciences last year, where David Olson from UC Davis took the position that subjective effects were not necessary, and we took a position that they are. I think the answer certainly has to be both. And then, of course, subjective effects are underwritten by changes in brain. But the question is, are they necessary? And if I were to bet, I would say that almost certainly they're going to be, subjective effects are very important, and we can talk about how, but it has to do with changing the narrative structure of how people see and experience themselves and the world. So where are we with respect to the neuropharmacology? So it's a very active area of research. Substantial progress has been made. However, the most salient features of psychedelics are that they produce this profound alteration in consciousness and the sense of meaning. And I think the thing that I want to underscore is that scientifically, we're just deeply ignorant about the nature of consciousness. There is something famously called the hard problem of consciousness. And that's the problem of explaining why any physical system is conscious or could be conscious rather than non-conscious. It's a deep, intriguing neuroscience and metaphysical puzzle. So there we are with respect to neuropharmacology. I now want to turn to what we have been doing with psilocybin in our program, which I mentioned has been going on for 20 years. And so to date, we have done studies in healthy volunteers, in novice and long-term meditators. We're completing a study in religious clergy. But what I want to focus in on is the clinical studies where we've looked at cancer patients, MDD patients. We're looking at the addictions. And we've just recently initiated studies in anorexia nervosa, depressed patients with Alzheimer's and comorbid depression and alcohol use. To date, we've treated over 400 participants, had over 750 psilocybin sessions. So we've acquired a good bit of experience so far. What I'm going to do is start by just describing some of the results we get in healthy participants, because it will illustrate how we run these sessions and the kinds of results that point to the direction of the therapeutic outcomes. So these are rigorous double-blind studies. Patients are healthy, and many of the patients in our preliminary studies in healthy volunteers were without histories of any psychedelic use. They meet with our session monitors on several occasions before the first session, and that's to develop trust and rapport with the volunteers, which is thought to reduce the risk of adverse reactions to psilocybin. And then we bend over backwards in the studies where we can to minimize expectancy bias. Studies are conducted in a comfortable living room-like setting. Volunteer comes in the morning, takes a capsule, swallows a capsule containing synthesized psilocybin. They're invited to lay down on the couch, use eye shades throughout the period of the 6-hour session, and headphones through which they listen to a program of music. They're in the company of 2 therapists or guides or sitters whose function is really just to create a safe container for the volunteer. So this is not interactive psychotherapy going on. In fact, we ask people to direct their attention inward on their inner experience, and we don't invite them to talk about the experience in real time unless they feel a need to do so. This shows the time course of these monitor ratings over a 6-hour period of a session. And this is just from a dose effect study. And so you can see we get very orderly dose and time-related effects, with effects coming on at about 30 minutes, peaking at 2 to 3 hours, and then decreasing toward the end of the session. By the time the session's over, the participant's ready to be released in the company of a trusted friend or family member. So under these conditions, what does psilocybin do? Well, it does just what we would expect a classic psychedelic to do. So there are perceptual changes, visual illusions, greater emotionality, sometimes increased joy or peacefulness, but it can also be significant fear or anxiety. We cannot protect against that occurring. And there can be cognitive changes like a sense of meaning, and sometimes paranoia can come up. Interestingly, however, and I think importantly to potential therapeutic effects, in most participants, psilocybin produces large increases on self-rated questionnaires that had been originally designed to measure naturally occurring experiences of a mystical type or an insightful type. And so this is data from a dose effect study in healthy volunteers, just showing the dose effect relationship of psilocybin on something we call the mystical experience questionnaire. And let that name not mislead you. This is not this this questionnaire does not imply the existence of or endorsement of supernatural kinds of phenomena. The basic qualities of this mystical experience are those of the interconnectedness of all people and all things, this deep sense of unity or connectedness, the preciousness of that experience, and the authoritative truth value of that experience. Those are the major features. And then post-session ratings of psychological insight, which can be manifest as autobiographical insights or insights into the nature of habitual behaviors that people are engaging in. But this is immediately post-session. So the interesting feature of psilocybin and these drugs that really set it apart from any other class of psychoactive drugs that I have worked with or know of is that the attributions to these experiences endure well after the time of the session. And they're very positive attributions to changes in attitudes, moods, and behavior. So here we are a month out of high dose sessions in healthy volunteers. And we have about 80% of people saying that experience a month ago was among the 5 most personally meaningful and spiritually significant experiences of my entire lifetime. So they might compare it, for instance, to the birth of a firstborn child or the death of a parent. And then there's about 90% are endorsing increased sense of well-being or positive behavior changes. And here we are out to 14 months. This is just illustrative. This was 5 weeks after high dose session. This is increased ratings of well-being or life satisfaction moderately or very much. And at 14 months, these remain very high. And this slide just illustrates the fact that this is not restricted to just reports from the volunteers. So in about 5 different studies now, we have had community observer ratings of volunteers' behavior and attitudes. And across the board, those confirm the positive kinds of changes reported by the volunteers. So that's kind of the setup. I'm going to turn to now therapeutic applications. I'll talk briefly about our cancer study, in some more detail about our major depression study that was published in JAMA Psychiatry earlier this year, a little bit about drug addiction. So this first study we ran and we published in 2016 was looking at depression and anxiety in cancer patients. These are people with a life-threatening diagnosis of cancer. It was 51 participants. This is double-blind, randomized, crossover design, comparing a pretty high dose of psilocybin with a very low dose of psilocybin under conditions that minimized expectancy bias. There were 2 8-hour sessions, 5 weeks apart. And after screening, people were randomized to 2 different orders. They either got the high dose first, followed by the low dose 5 weeks later, followed up at 6 months, or the inverse order. And I'll just cut to the chase with respect to outcomes. This is the HAM-D, a gold standard measure of depression. And what this is showing in the orange is 5 weeks after the high dose session, 92% of the participants are showing a clinically significant improvement. And to meet that criteria with the HAM-D, it has to be a 50% or greater drop, much greater than placebo. And then interestingly, these effects are sustained at 6 months. So a single dose of psilocybin is producing these large effects. Here's remission to normal range. On the HAM-D, that would be a score of 7 or less. And so at 5 weeks, we have 60% in remission, 70% at 6 months. Almost identical kinds of results on the HAM-A. So the conclusion here is that single moderate high dose psilocybin can produce substantial and enduring decreases in depressed mood and anxiety in patients with a life-threatening cancer diagnosis. And published concurrently with ours was a very similarly designed study, a randomized trial from NYU that showed virtually identical results. So we have 2 randomized trials showing this effect. So I'm going to turn now to major depression, and happily just this last week, Newsweek ran a cover story entitled "Magic Mushrooms May Be the Biggest Advance of Treating Depression Since Prozac." Now that's getting that's into the cultural hype now that's surrounding this, but these kinds of findings have landed very positively in our culture, and it's sometimes I'm concerned overly so, but I thought I would point that out. So this is a study that was published online last year. It came in print this year. It was a randomized delayed treatment or waitlist control trial examining the efficacy of 2 psilocybin sessions, 20 milligrams per 70 kilogram on the first session, and then 30 milligrams per 70 kilogram under these classic psychologically supported conditions. And this shows the basic study design. After screening, people were randomized to either an immediate treatment condition, in which they went immediately into preparation sessions with their therapists. They had 2 psilocybin sessions about a week apart, followed by blinded HAM-D ratings a week later and 4 weeks after that. And the delayed group got the same ratings of HAM-D, and then they were subsequently crossed over to the active condition. 24 participants, mean age 40 years, more females than males, mean duration of illness 22 years, duration of the current episode 24 months, 60% almost failed 1 or more medication trials. Baseline HAM-D was 23, which is a significant level of depression. And this slide shows the HAM-D scores, showing that the delayed treatment group showed no change over this period. The immediate treatment group, this is at 5 weeks, that would be 1 week after the last psilocybin session, showed large decreases, maintained low at 8 weeks. These effect sizes of greater than 2.5 are astounding. And this shows just the same data collapsed across both the immediate and delayed treatment group after the delayed treatment group received the active treatment. So big decreases. And at 4 weeks, there was a 71% response rate. That's greater than a 50% drop, and 54% remission. This shows data from another measure of depression, the QIDS. And I showed this because we also assessed the QIDS the day after the first session. And you can see that we actually get what appears to be almost maximal decreases in the QIDS at that time, and it maintains low, suggesting that perhaps a single dose of psilocybin is sufficient to produce these kinds of effects. This is the BDI, another classic measure of depression, showing again huge effect sizes. Here's the HAM-A, big effect sizes. Here's Columbia Suicide Severity scale in both cases, no difference, and there is just decreasing across the trial. I want to just touch the only other randomized trial of psilocybin, and this was notable because it was published in New England Journal of Medicine just this year. This is out of the Imperial group. And it was interesting because what they did is compared psilocybin to escitalopram in major depression. So they had two groups, a psilocybin group that received 2 sessions of 25 milligrams of psilocybin 3 weeks apart, and then daily placebo capsules for 6 weeks. The other group received 2 sessions of psilocybin, but a trivial dose of psilocybin, and they received then daily escitalopram capsules for 6 weeks. It was 60 participants, 19 years of illness, baseline HAM-D a little lower than what we had. Well, somewhat disappointingly, although they showed directionality of effect, this is the psilocybin group here, here's the escitalopram group here. They failed significance in their primary outcome measure. And here's a well-being measure. There's a big difference there. So they had to declare this as not showing therapeutic effects of psilocybin. However, that must have been a very painful choice they made with respect to their primary outcome measure, because they had a variety of other outcome measures. And what's shown here is confidence intervals across a range of different measures. And with respect to confidence intervals, if the bracket crosses over this dashed line, then it's not significant. So this is their major outcome, their declared primary outcome, which was the QIDS. And so they fail significance there. But on the HAM-D, on the MADRS, on the BDI, and on various other measures related to therapeutic outcome, including suicidality, they all showed significant effects. So I'm inclined, despite the conclusions that they were forced to draw, to suggest that this really points very significantly to some kind of positive therapeutic signal for psilocybin consistent with our study. So what's the status right now of the regulatory status with psilocybin? So FDA has given breakthrough therapy status to 2 different companies that are initiating psilocybin studies for indications of either treatment-resistant depression or major depressive disorder. And if successful, these trials may result in approval of psilocybin for medical use. So it's very difficult to forecast the FDA process and what hurdles they might run into. But if I were to make a best guess, I would say the earliest approval date would be 3 to 4 years, and more likely 5 to 6 on the outer edge. So I wanted to share some other data related to depression, and that's the question about psychedelic use among those who are on mood stabilizers. So there's very little limited information about the use of classic psychedelics in patients with mood stabilizers, which of course are commonly used to treat bipolar disorder. And this is important because patients with bipolar disorder may attempt to treat themselves with psychedelics while on a mood stabilizer, because particularly given all of the enthusiastic coverage that has been that's occurred with respect to efficacy of psilocybin and other psychedelics for depression. But yet, bipolar patients have been excluded, to my knowledge, from all of the studies conducted to date. There's one group now that's initiating a study in bipolar, but there's concern about whether or not it could touch off mania or some kind of psychotic features And so it's just been a subgroup of depressants that we've avoided. But nonetheless, this is a question, well, so are these people at risk? And we have a psychiatric fellow working with us, Sandeep Nayak, who's a very talented psychiatrist. And what he did is analyze reports of use of classic psychedelics among those taking mood stabilizers. And he scraped 3 different websites, Erowid, Trumery, and Reddit, for reports of this type. And each of these websites allows people to post experiences. And he came up with this very cautionary observation about lithium. 47% of the 62 cases of lithium plus psychedelics involved seizures. An additional 18% resulted in bad trips, while none of the 34 lamotrigine trials did. About 40% of lithium reports involved medical attention, not surprisingly, because they had seizures. In contrast, 65% of lamotrigine reports, but very few of the lithium reports were judged not to be affected at all by psychedelics. So it touched on the issue of palliative care, and I'm just going to show this single slide to make the point that there's every reason to think that in addition to depression, psychedelic treatment of addictions may be a very promising area of investigation. So we have done a series of studies with cigarette smokers, and this is my colleague Matt Johnson at Hopkins, have resulted in very promising results. We had in our initial pilot study 80% abstinence rates at 6 months in people treated. We have a control trial going, and Matt just last week was awarded the first NIH grant to study a psychedelic for a therapeutic indication. And that, can't tell you, that is a very big deal, because all of this research, or most of this research, has been funded by philanthropic and private sector support up to this point, and none of the therapeutic trials have been. So for NIH to overcome their inertia and conservatism and step out and start funding this research is a very salient point. But there's also very promising data in alcohol use disorder, and Michael Bogenschutz from NYU has been doing this. And Peter Hendricks at University of Alabama, Birmingham, has some promising initial observations with cocaine use disorder that haven't been published yet. But I'm thinking of this as a major additional therapeutic wing that will be promising. I talked quite a bit about the neurophysiological underpinnings, the mechanisms accounting for these effects. I'm just going to mention these are the psychological and cognitive mechanisms that may be at play, and don't have time to really unpack them. But mystical experience, including this enduring and authoritative and highly valued sense of connectedness, appears to be important. Actually, in those experiences predict therapeutic outcomes and positive effects across a range of studies. Another not entirely separate mechanism is ontological shock, resulting in profound shift in sense of self and worldview that can result in major belief change, which has become a real interest of ours, and a loosening of the self-focused narrative and reconstruction of life story. Then there's insight. I mentioned insight could be insight about self or relationships, which can be experienced as memory or catharsis. Many people report increased self-efficacy or agency after these kinds of experiences. We've documented increase openness in the personality of openness to new experience. There's curiosity about the nature of mind or consciousness, interest in mindfulness, and very often a greater tolerance among those people who are in conditions of suffering. There's greater tolerance for and interest in benefiting from discomfort. We think mechanistically, this is a path analysis from some survey data. We think mechanistically that these acute mystical experiences and acute insightful experiences feed into this measurable domain of increases in psychological flexibility that then account for decreases in depression and anxiety. So turning to conclusions and the implications. So what I think I've tried to show here is that under the conditions of these studies, psilocybin occasions discrete experiences that have actually marked similarities to classic mystical and insightful type experiences. And these experiences are associated with enduring positive changes in attitudes, moods, and behavior in both healthy and in patient populations. The finding that psilocybin can occasion in most people studied, and that's 70 to 80% of people, these kinds of experiences virtually identical to those that occur naturally as a mystical type experience, suggests these experiences are biologically normal. That is, we're wired for such experiences, and suggests that these experiences now, which have been elusive in terms of study, are now amenable to systematic prospective study. And the exciting part of that, to me, is that it opens up this huge range of research opportunities. And that's why I'm excited to hear that there's a group at University of Washington interested in this. We can cut this at various levels, but in terms of biological psychiatry, how do factors such as personality, genetics, personal intention affect the likelihood of these kinds of experiences and their enduring changes? Neuroscience illustrated that, what structural, functional changes in brain can account for these both acutely and enduringly. Behavioral sciences, what behaviors are changed, what kind of valences are going on, and what behavioral mechanisms might account for such changes. And then, of course, therapeutic applications. There are a host of therapeutic applications. I mentioned several directions that we're doing exploratory studies at Hopkins. We have a number of other studies on the drawing board, including opiate addiction, PTSD, OCD, combined alcoholism and depression. And then finally, there's a broader question about altruism and pro-social behavior. One of the unique features of these experiences, particularly of the mystical type experience, is this profound sense of the interconnectedness of all people and all things, the deep sense of the truth value that we're all in this together. And from that often arises a sense of mutual caretaking. And my thinking about this is that's a very, very interesting target in and of itself, apart from the therapeutic applications. So thank you very much for your attention.
Well, thank you, Dr. Griffiths. What an informative, impressive presentation, including results of clinical trials as well that we can all think through. Several questions have come in. We've got a couple of minutes. I do want to pose one question first about how you described subjective effects of individuals taking psilocybin, about the narrative structure of how people see themselves in the world, which is interesting. It sounded a lot like an outcome of psychotherapy. And I wondered it's interesting to consider a pharmacological effect on what maybe we currently think of as a psychotherapy type outcome. Would you comment on that?
Yeah, well, I think that's the best way to understand what's going on is that these kinds of substances enhance the psychotherapeutic process in unique ways, in ways that we don't understand. But, a given in working with psychedelics is that set and setting, the whole set of expectation and how people are prepared and what kind of aftercare they have are very important determinants of this. And of course, that's what the psychotherapeutic process is about. And so I think there's a lot we have to learn about that interaction. And it'll be really fascinating to explore. And I would also just say very humbly that we're just at the infancy in terms of understanding that. FDA is going to really have to wrestle with that question in approving these compounds, because you cannot subtract out the therapeutic package. But right now, within our culture, the context, those expectancies, and the belief systems of people who are offering this kind of experience diverge widely from those that may be standards within our culture, and we need to come to some consensus about the best way to do that.
Dr. Griffiths, there were several questions about this phenomenon called microdosing. Has that been studied? I mean, you talked about a microdose in this study done in the UK, for example, 1 milligram. But what are your thoughts?
So microdosing has just gotten a huge amount of attention, and there's very little systematic research that's been done on it, and to my lights, nothing convincing enough to know for sure that these aren't largely placebo effects. I suspect they're not. I suspect there's something there, but as we know, placebo effects can be, these are expectancy effects, can be incredibly powerful. And for most of these clinical observations, they're being done under unblinded conditions. So I think it's simply too early to say. That being said, there are people who report very significant benefits. So it's a very important area of research that deserves to be undertaken. But we and others really haven't done what needs to be done to parse that out.
Thank you for addressing that question. We're actually a minute over. Dr. Griffiths, may I pose one more question, exceeding our time here? Okay, a group of questions came in about some of these things. Experiences might sound like psychosis, some might sound like a dream state. Are they similar in the brain, or are they? How different are they? What do we make of sort of experiences that maybe clinicians are more familiar with observing or treating compared to what's occurring with psilocybin?
Well, thank you for that. I think it's the very nature of the similarity to psychotic process or manic process and some kinds of thought disorders that's made psychiatry so suspicious of the psychedelics. So understandably so. And I can tell you, within my very conservative department, when we initiated this work, it was not greeted warmly. There was deep skepticism. That said, there is overlap in phenomenology, but there are also very substantial differences. So one of a prominent psychiatrist in our group, was insisting that this was just dementia, and it's certainly not that. There are features of it that look like delirium, but the meaning and the value that are placed on this in a very positive light, really pulls it apart from any kind of classic psychiatric condition. But I do think we need to continue to explore those relationships. Initially, when psychedelics came available clinically, they were called psychotomimetics because of the very thought that, oh, this is a model system for understanding psychosis. And I think we've evolved past that now. That remains an area of interest, but it certainly is not, cleanly a psychotic type process.
Well, thank you again, Dr. Griffiths. I acknowledge to the many participants who have posed questions that we just don't have time for today. I'm sorry about that. But we've learned a lot today, and we've heard a great presentation on this topic, which is, as you learn, motivating a research group here as well. So thank you to the participants. Thank you, Dr. Griffiths, for presenting and joining us today.
My pleasure. Thank you.
Take care.
Bye-bye.